Good morning. My name is Edward Czerwiński. I am Professor Emeritus of the Jagiellonian University and Senior Medical Director of FutureMeds. This is the fifth lecture of Academy Osteoporosis. I hope you watch already the previous one, but you can do it later. So, fracture risk assessment. I'd like to talk about first to treat, calculator FRAX. We show you how it works, Trabecular Bone Score, in the fracture assessment, explain to you the issue of diagnostic and therapeutic threshold. So who to treat? It seems to be very obvious. In osteoporosis, the goal is to prevent the fracture. So we treat the patient who is diagnosed with osteoporosis. It means T-score minus 2.5 or less. But we know that fractures occur, the majority of fractures occur in people with osteoporosis. So we treat the patient who is at risk because the fracture is the issue of osteoporosis. But everyone has a risk of fracture, me, you. So we treat the patients who have a higher risk than the general population. We are not going to treat everyone. And how to find this patient and be sure that it is right, this lecture about. The first step was done in 1984, when WHO published the assessment of fracture risk, and it was the threshold value of BMD minus 2.5. So who had the value of 2.5, that means got the osteoporosis, and we have the category of osteopenia, osteoporosis, and severe osteoporosis. And this looks fine. But this is the most often shown slide of CRFs. And here we have in red the number of fracture. And in this, we have the distribution of fracture. And here is the barrier of minus 2.5. So as you see, majority of fracture, 55 to 74 fractures occurs in those who have no osteoporosis using WHO criteria of T-score minus 2.5. And this is even worse if we look at the women who sustained a proximal femoral fracture. Here is 234 patients, and as you see, 54 have not osteoporosis. So they will be not diagnosed as osteoporotic, and they will be not treated. And we have a very similar situation in cardiology, and we are afraid of heart attack. So we do ECG. But if this lady has normal ECG, can anybody say that she has no heart risk attack? No, definitely not. So if somebody will do BMD assessment of that lady, and her BMD will be within norm, that means the diagnosis of osteoporosis will be excluded according to WHO criteria. Can anybody say that she has not any risk of fracture? Definitely not. So this is why we have to remember that the decreased BMD means definitely increase of the fracture risk. It is the strongest indicator of fracture risk, but the correct BMD does not eliminate that. Why it is? We have a huge Sweden data, and here we have the fracture risk probability in percentage, and here is age and T-score. So here is the row. We have T-score -2, not 0. So in a lady at the age of 64, her fracture risk will be 9.2%. But in a lady which have 76 years old, her fracture risk is 19.2%. Why it is? Because we have various fracture risk and we have absolute fracture risk, taking into various fracture risk factor. And this is why calculator FRAX was established. Here we have another Swedish data. So if there is, say, normal or average Swedish woman, and at age of 65, at height 171, and such a weight, she had a normal BMD 24. So if she has no other risk factors, her normal risk factor will be 2%. And we can say this is a population risk. But if she will be smoking, her risk will be 3.2%. If she had a fracture in her mother, the risk is 4.5. And if she has a previous fracture, her risk will be 70%. If we have multiple risk fracture, they have been magnified. So this is the critical feature population risk. And here is the critical feature threshold risk, because if a lady has a fracture, she needs treatment, no discussion. I thought how looks the normal woman, a Swedish woman, and I found that Margaret Thatcher, published in Therapeutic, highlights as just BMI 24, where she was 43 years old, and when she was 83 years, she broken her forearm. So in 2008, Professor Canis, under the auspices of WHO, published FRAX. What is FRAX? Is the calculated tool based of the prospective data of 230,000 patients with 300 proximal femur fracture with various population, 10 years population. After we knew the data 10 years before and 10 years later, so we knew who had fracture, so we can calculate the risk. And we knew, of course, the various factors, so we could establish the worth of every risk factor. This FRAX was updated 2022, and look, the cohort was 65, patient 2 million, person 20 million, and 42,000 proximal femur fracture. Enormous material who allows Canis to calculate very precise and almost new risk factors. I will talk about this later. Fracture is different in different countries. In Poland, we have 262 10,000, and in Sweden, we have more than 1,000. So there are various calculations in the continent, in countries, 80 models and 18 languages. So we have to, before we start, we have to adjust it. At the moment, it covers 90% of the population, 41 million of calculation done already. So FRAX is based on the fracture risk. We put the age, sex, calculate BMI, so giving weight and height, then the previous fracture, parent history of the hip fracture, smoking, glucocorticoids, rheumatoid arthritis, secondary osteoporosis, alcohol means 3 units per day, and we can add, but not necessarily, the femoral neck BMD. We put it and calculate the data for lady of age 67, weight 78, height 178 centimeters, BMI 27.6, and T-score minus 2.3. That means she has no osteoporosis. I advise you watch my video so you can log in, typing just this ref, or just in Google FRAX Sheffield, or just copy the queries code. You can use computer or your portable. Off we go. So I am in incognito mode, typed FRAX Sheffield, got it, and here we are. I go for calculation tool in Europe and in UK. And the patient name will be Margaret Thatcher. That she at age when she was 67, and she is female. Her weight is 78. Her height is 168. And here I will go for T-score. So I open that. Bar has T-score. Some information. And I type minus 2.3. Means she has no osteoporosis. And here we go. Here we go. She has major osteoporotic fracture, 12%, and hip fracture, 2.7%. Thus, we ended with the calculation that this lady have major risk fracture 12% and hip fracture 27%. But if she will have a previous fracture, her risk immediately rises up to 19%. So that was it, FRAX, traditional FRAX. And now we'll talk about advantages and TBS. FRAX Plus, published in 2022, may adjust it to the recency of fractures. I will talk it later. Probability of glucocorticoid dose, TBS, diabetes, falls, differences between results of femoral neck ends and the spine, and to the femoral hip axis length. So we go for show you how it works for the TBS. So let's remind you, we have 3 categories of TBSs: normal, partial degraded 1.23. I will use a degraded less than 1.23, and I choose calculation for a patient who had the best one in my career, 1.48, and the worst one, 0.84. So here we are back to our chart, and we press the adjust with TBS. We are on the TBS. Yes, we want to adjust. So I make calculation, and here I put the, you have to select the DEXA, of course, which one you have. And I put 123, and I got the result 13, so no change, perhaps. But if I put the best one, the fracture risk get much more smaller, 10% instead of 12. And if I put the worst one, not 0.805, the fracture risk jump up to 23, so almost twice. This is the worth of the TBS calculation. Remind you, this is the independent risk factors. I strongly suggest you to use it. So we now go for the diagnostic and treatment threshold. Diagnostic threshold is very easy. WHO minus 2.5 or less, osteoporosis, done. But because majority of fractures occurs in women with normal BMD, so there is general agreement that treatment threshold absolute. If a lady got a fracture, she has osteoporosis, she must be treated. If any other situation or risk factors, UK just FRAX value, because now it includes all possible, almost all possible fracture risks factors. US, you have now the references. T-score means osteoporosis in the hip or spine. In osteopenia, in the FRAX, more than 3%, and MOF more than 20. Fibovertebral fractures, regardless of BMD, and distal radius fracture, proximal femur and pelvis with osteopenia. That's the threshold. Everybody have to take another consideration, which are not in this scheme, mean secondary osteoporosis, glucocorticoids, diabetes, and etc. How works the IOF recommendation? Here we have the FRAX results based of the standard woman. This is the, and when she was at 50, so her risk will be 5. If she is 80, her risk is 18, something like that. So this is the population risk. Above the population risk is the patient which you have to consider to treat. And there is the level of threshold for patients who have a fracture. It is the percentage of 80 lady, and this percentage about, say, 8 if she will be 60. And the upper threshold means if it has a higher FRAX result, means that this patient can be treated without checking BMD at all. I will return to back in the next session talking about very high risk. Now we are stopped with the high risk and upper threshold. So we come to conclusions. The goal of, because of the fracture is the problem osteoporosis, so we have to identify patients who are at risk and the risk greater than the general population. FRAX calculate absolute fracture risk based off various risk factors like BMD, BMI, gender, age, prevalent fracture, fractures in parents, steroids, and many others, including TBS. FRAX calculate 10 years of absolute risk of the major osteoporotic fracture, meaning proximal femur, spine, radius, and humerus, and also only for the hip. The therapeutic threshold in FRAX is for a person who is 50 years old and have no other clinical risk factors is just 7%, and such a lady should be treated. Trabecular Bone Score is an independent risk factor and can make more precise FRAX calculation and may lower it if there is a very good structure or even double if there is very best structure, means from 12% to 23%. FRAX beta takes into account others like TBSs, locational fracture, those of recovery, falls, duration diabetes, and many others. So it makes the FRAX calculation much more precise. With that, I'd like to thank you for your attention, and I hope you will join in other lectures. You are really welcome. Please write down your comments, questions, and so on. It will make me happy if you do it, please. Bye-bye.